Now let's go through and talk about some of the findings that we're going to look for. Remember, there's only really 4 things we're going to look for, and then we're going to clinically integrate that information. So pneumothorax, first off, we know the symptoms: pleuritic chest pain, shortness of breath. Most of the time we think about this in trauma, but don't forget, especially in the West Virginia population, we've got lots of patients with COPD and probably have bulla and can have spontaneous pneumothoraces, and plus the other kind of classic textbook patients who can get spontaneous pneumothorax as well. Now here we're looking at this with a linear probe, and this is one of the things you can use to look at the lungs, but you can see these findings with a little practice with any probe. The main thing we're going to see in pneumothorax is lack of sliding, and we may also see a lung point, and I'll show you what those look like. But I want to really get your eyeballs trained at seeing the normal findings, which are ribs, pleural sliding. You see that movement going along the rib, and then the rib shadows here. If we see this sliding, then that lung is up. The visceral and the parietal pleura are opposed together and they're normal. Sometimes in normal lung, you'll see these little artifacts. Some people call them comet tail, bright white artifact. They just sit right about the pleural line. They don't really dive down into the lung area themselves. Indicators towards the head, and often the best place to look for pneumothorax is the most anti-dependent area, or the place closest to the ceiling, because air likes to rise, correct? So they're just pointing out the findings. Make sure you kind of get this pattern locked into your brain. So here's a comparison of findings and what they might look like with the high frequency or the linear transducer. Here to your left, we see ribs and some shadows. We've kind of taken those off to the side, and we see nice pleural sliding and those little tiny artifacts that come down off the pleural line I told you about. Over here, we can see ribs that are kind of off of the edges with a little bit of shadows. We see that pleural line, but there is no sliding motion. We can see the chest wall up here not moving much, and we can see the whole thing moving a little bit, but we look right at that pleural line. The pleural line goes right under the ribs. That's where we're looking. It should be bright white, and there's no sliding here. So this is a case of pneumothorax compared to normal. So that's what absence of pleural sliding can look like, and that generally is going to be indicative of a pneumothorax. Now there's a few false positives, but in general, especially in the right scenario, this means pneumothorax. Now, just to point out that we can see what this looks like and see examples of this with the higher or with the lower frequency probes. I'll point this out again. So here we see the ribs are off to the side. We've kind of angled so they're out of our immediate view, but we can see that lung sliding. We get our eyes practiced. We got to hold the probe really still and look for lung sliding. We can see that little shimmery look of the pleural sliding, and nothing else below here looks abnormal. And over on this side, where we maybe didn't hear lung sounds, the ribs, we've got those off to the edge, but there is no sliding movement anywhere. So this is absent pleural sliding, again likely indicative of pneumothorax in the right clinical scenario. If the patient is splinting or not breathing, or maybe they're intubated and you've got the right main stem and you're looking at the left, maybe you might not see sliding. Scar tissue from prior injuries or pleurodesis may affect this. So as always, with all ultrasound and everything else, use the whole clinical picture and make your clinical decisions with all the information that you have. So we see sliding there and we don't see it on the other side. So get your eyes looking at that, get them practiced at seeing the difference. Now the next little thing you can see in pneumothorax is lung point, and lung point is the area of transition in pneumothorax. Just like where we can see the attachment on a CT or an x-ray where the lung is up and there's a transition where the lung is up to where it's down, lung point is the ultrasound equivalent of that. Part of the lung is seen sliding normally next to an area of absent pleural sliding. Let's take a look. So here to your left we see an example of where we don't see any sliding and then just intermittently that lung pops up. So that's a lung point in action that we see there. Over here on this side, we see we're looking in the chest, we see rib shadow, we can see the pleural line, and there's no sliding here whatsoever. And then intermittently, this lung kind of pops up in and out where the lung is opposed to the parietal pleura and coming down. So this is another example of a lung point. These are definitive, pretty much 100% specific findings of pneumothorax, lung point. You're not always going to see this because you have to be in just the right spot, but if you do see this, you can be pretty much guaranteed that this is pneumothorax. Now in this case, we also see a little B-line or two. We're going to talk a little bit more about those coming up. So this brings us back and is relevant in the first case we talked about. So charge nurse grabs you, this patient looks really sick, you're getting ready to think about intubating, but before you do that you want to take a quick look at their lungs. There's no time to wait for the x-ray, and you look in their lungs and realize, hey, up here no sliding on this right side. We've got rib shadows, we've got pleural line. On the other side, we can see there's lung sliding, but this side there's no sliding. So this is a patient with probably underlying COPD, had a little blood, popped, and caused a pneumothorax. So with that information, you withhold intubation, because if you intubate this person, cause a tension pneumothorax, they're probably going to go into cardiac arrest. So you may have just saved this patient's life with ultrasound. Instead, you place a catheter, drain the pneumothorax, they have drastic improvement and don't need to be intubated at all. So life saved. Thank you, ultrasound. So that's pneumothorax. The next thing we're going to talk about is pleural effusion. Now this is a pretty easy and straightforward thing to find on ultrasound, but if you're not looking with ultrasound, you're going to miss this on a lot of chest x-rays, because chest x-ray is just not that sensitive at identifying pleural effusion. And even when you see something that looks like pleural effusion on chest x-ray, it's not a guarantee that it's truly effusion versus consolidation versus mass versus empyema or what. So ultrasound can drastically help us with this. Patients with pleural effusions are usually short of breath. Maybe will have diminished breath sounds or dullness to percussion. I don't do a lot of percussion in my practice, but if you do, there you go. So with pleural effusion, you're primarily going to be looking at these in dependent areas. So that's why when I come out to the sides, I like to increase the depth on my ultrasound machine and find the diaphragm first, because I usually want to know quickly, is there a big pleural effusion or not? And if we identify the diaphragm, as we see here, and then kind of fan from posterior to anterior, we should be able to identify pleural effusion if it's there. So what we'll see is some kind of fluid above the diaphragm, and we can judge the size and follow it up and see how high it goes. Here, this is probably not that large, because we can see there's just a small space between the diaphragm and the lung. And I'll also point out that we can start to see other structures that wouldn't usually be visible. You take a look here underneath the bar, we can see the spine going all the way up in the chest past the diaphragm. It's the fluid that allows the sound waves to get to the spine and give us that reflection. Same thing over here. We can actually see the thoracic aorta in the chest, because the fluid in the chest is letting us see all the way through to those posterior structures. So this is a large pleural effusion above the diaphragm. This is a smaller one, and here's where we actually hit the lung. We can kind of see pieces of the lung peeking in and out here. So when we go to those side views, we want to increase the depth so that we can identify pleural effusions and then try to estimate how large they are. And just to point out the findings a little bit more, so you can see the diaphragm, the fluid, and then the spine sign in the chest. So if we see the spine in the chest above the diaphragm, there's definitely something wrong in that lung, either fluid or huge consolidation or empyema or something. Just one more time, take a look, see what those findings look like. X-rays uniformly miss or underestimate the size of these things. And now sometimes, again, X-ray is never really going to be good at differentiating this, are empyema. Empyemas are very complex fluid collections or abscesses in the pleural space. They're going to be very complex and irregular with lots of stranding. Now you may see some little floating fibrin strands in a more simple pleural effusion, but these things are relatively fixed. They're not moving around. They're very complex, and no matter how you move the patient, there's really no shift in dependent areas, because this is all complex and thick, nasty fluid. And maybe you can get a chest tube into these. The treatment for these is going to vary depending on how severe it is and what your scenario is. Ultrasound is definitely the best way to identify and characterize empyema. Even on CT, the contrast resolution is usually suboptimal to fully characterize empyema in the chest. So we talked about pneumothorax, we talked about pleural fluid collections, so now we're going to talk about pulmonary edema and what that may look like. This is probably one of the most important clinical scenarios, because a lot of times when we have acutely short of breath patients, our big question is this a cardiac cause of dyspnea or some other cause? And we can recognize this in minutes, even seconds, by applying lung ultrasound, often paired with cardiac ultrasound. So the primary finding in pulmonary edema is going to be sonographic B lines. So what are B lines? Well, they're non-specific indicators of interstitial fluid. So just themselves, they don't represent pulmonary edema, they represent interstitial fluid. Importantly to recognize them, they start at the pleural line. So here we see ribs, and there's little shadows from the ribs. These B lines start at the pleural line, they should not be above, and they go pretty much all the way down to the bottom of the screen. They're bright white, and they're actually artifacts, so that you can almost see these repeating multiple lines. We won't get into that too much. And here in a second, when you see the pleura move, they are going to move with the pleura, and that's what B lines are. The pattern and the distribution distribution of the B lines is going to tell you clinically what their significance is and what they mean. So just a few arrows to kind of point things out and help you recognize what we're seeing. So hopefully you can see those B lines there, how they go all the way down. Now let's watch those move. You see them move with the pleura, bright white vertical lines that go all the way down, move with the pleura. These are B lines. And in pulmonary edema, what we'll see is a relatively clean line at the pleura. Pointing them out one more time, see them moving, those are B lines. So B lines are a non-specific indicator of interstitial fluid. So the pattern and the distribution, along with the clinical scenario, is going to tell you what their significance is. So if it's pulmonary edema, they're going to have a pretty symmetric and uniform distribution, and you're going to have a pretty clean pleural line. With pulmonary edema, we're just seeing interstitial fluid. Sometimes we'll see some pleural effusions as well. Some of the other things where you can see B lines are pneumonia. Now in pneumonia, they're usually going to be in a focal area or very irregularly distributed, and we're usually going to see some pleural irregularities or even some infiltrates or consolidations, and we'll show you what those look like. Pulmonary contusion, well, that's going to be in the setting of trauma. It's usually going to be pretty focal, but we can see B lines in that scenario as well. Atelectasis, sometimes that can also introduce B lines. That's usually going to be in dependent areas, and actually it's pretty common in anyone who's been lying in a bed for a while to see a few small areas of B lines in dependent areas. The more B lines you see, the more significant they are. So with recognizing some of those findings we've talked about, like B lines and pleural effusions, that can help us make sense out of case 3, this 54-year-old who was short of breath and not vague history of heart disease, smoker. We don't really hear it because they're not moving much air, but we take a look with lung ultrasound and we see all these bright white B lines on both sides, so pretty symmetric distribution, and we even see a pleural effusion as well. So findings that our exam really didn't reveal to us, weren't that clear on the terrible quality chest x-ray that maybe you got or you're waiting for. You can wait an hour and a half for your BNP to come back, but this patient's sick and you need to make decisions now. We pair in cardiac ultrasound and recognize that this person has poor left ventricular function, so we can tailor our therapy and give them the right therapy quickly with BiPAP, nitroglycerin infusion. Maybe we need to diurese them, and maybe we even need to do a thoracentesis, and we can help this patient manage them and avoid inappropriate therapies and get them dispositioned appropriately. So the last thing we're going to talk about is pneumonia. Now pneumonia has some overlap with some of the findings, but the clinical scenario and the distribution of findings is going to be different. So the findings in pneumonia are focal or irregularly distributed B lines, usually pleural thickening or other pleural abnormalities, and then we may see subpleural lesions or even kind of large consolidations. So let's take a look at what those look like. B lines are going to look about the same, but they may only be in a focal area, or they may be kind of patchy, skipping around. Then we're also going to see abnormalities of the pleura where it's thickened, kind of ragged and jagged and cut out. So the findings, like we talked about, the B lines are going to look pretty similar, but the distribution and the pattern is going to be different. So here are B lines, but in pneumonia, they're going to be in focal areas, or they're going to kind of jump around, skip around, be irregularly distributed. And usually we're also going to see thickening or irregularities at the pleural line. See how this is real jagged and pulled out, and we see B lines kind of jutting down from different areas. These are findings that suggest an inflammatory or infectious process. Similar thing here, very irregularly jagged. You can even see this little pucked out area. These are little small consolidations, and we see B lines associated with that. If you see these things, then this is going to make you think that this is a pneumonia and not pulmonary edema. Sometimes in even very large consolidations, we'll see air bronchograms. Air bronchograms are white because air is white on ultrasound. And if it gets really severe, the lung is going to start to look like liver. So this is not, in fact, liver we're looking at. This is a lung with very severe consolidation. So let's just point out those air bronchograms, and then let's watch this moving in real time. So we can see those are dynamic air bronchograms because there is some air moving in and out of the bronchi. We can see the heart beating down here in the corner. So this is a very severe consolidation. Just one more time, there's the air bronchograms. This is hepatization of the lung, a severe consolidation. So bringing this back in, we have our case 2 that we talked about, this middle-aged, older male with acute shortness of breath who has a history of COPD and CHF. You hear crackles in their lungs, so kind of your first inkling is, oh, this is CHF. Maybe we need to do nitro diuresis, which on further investigation with lung ultrasound would be very bad form and be harmful to this patient, because what they've got is pneumonia, where we see kind of this area of normal lung, then we see a focal area of lots of B lines, irregular, ratty looking, gnarly pleura, and we actually see reasonable cardiac function. Of course, we do some other views, so that can help us tailor the therapy, give the patient the right therapy they need, and not cause unnecessary problems. So able to treat the pneumonia, actually decide that they're bordering on sepsis, so we're going to carefully give them IV fluids, and most importantly withhold some things that probably would increase their mortality, like nitroglycerin and diuresis in this patient with pneumonia and sepsis. In summary, like we talked about with lung ultrasound, there's really 4 big findings: pneumothorax, pleural effusion, pulmonary edema, and then pneumonia, which is a constellation of findings. Look for these things. Often we're going to pair our lung ultrasound with cardiac ultrasound to give us the kind of full cardiopulmonary picture to help us tailor our decisions quickly and be accurate in taking care of our patients. Lastly, in summary, do immediate ultrasound in patients who are short of breath. Often you're going to want to do the heart as well. It's rapid, it's accurate, it's going to help us avoid diagnostic error and give more appropriate and more tailored treatment plans for our patients. So that's everything with heart and lung ultrasound. I hope that was useful for you, and I hope this helps you here in the near future take care of your patients who have cardio and or respiratory complaints.